And Susie, can you see my slides okay?
Let me see because I have, oh yeah, perfect. All
Yeah. Okay, great.
right, so we are live. And it's my great pleasure to have today with us Elizabeth Pienkos. She's going to present her talk on peripartum psychosis and the madness of motherhood. We are No Bump No Care, which is a network of professionals, scholars involved in making the life of parents, caregivers easier, and defending the rights, the reproductive rights of people. So, as I said before, Elizabeth Pienkos is a wonderful guest we're going to have today. She's a licensed clinical psychologist and an assistant professor of psychology at UK University. She specializes in phenomenological approaches to schizophrenia, employing qualitative methodologies to investigate the experiential features and the underlying structures of these and related psychiatric conditions. A recent scholarship advances the field of phenomenological psychopathology by developing models that more fully account for the embeddedness of subjectivity within social, cultural, and historical contexts, paying special attention to peripartum psychosis and maternal mental health. Thank you, Elizabeth, for accepting our invitation. I look forward to your presentation. The floor is all yours.
Thank you so much, Susie, and thank you for inviting me today. I'm really excited to share some of this recent work. And I want to note and really express my gratitude to a number of people that I've been working with on this topic for a few years now, especially Cynthia Dorstein, who is my co-author on the paper that some of this talk draws on. So really, really grateful to her for all of her work with me on this, and also to many of my students, and I'll be speaking to some of their work. One of my students who's joining us today, Tate. So good to see you here, Tate. I also want to note that today I'm going to be talking about mothers and women's experience primarily. So I'm talking about cisgender female experience. I have kind of made that choice to kind of focus in on a particular set of experiences, recognizing that there are other experiences of motherhood and parenthood that are very relevant here, but that things get very diverse. And so I don't want to lump all of that diversity into one set of experiences. So just to note some of the decisions around that. Without further ado, I want to just share a little bit about my own experiences of pregnancy. I am a mother of a 5-year-old, almost 6-year-old. This is an image of her from an ultrasound when I was pregnant. When I was pregnant, there was a lot to get used to, a lot to wrap my head around. One of the first moments that I really found myself just not able to think, I just couldn't think this moment, was when I felt her kick for the first time, and then also started to hear her heartbeat on the ultrasound. This sense that there was somebody else inside me that was both mine and not mine. There's this thing happening in me that I'm not directing, I'm not in charge of, but I can also feel in a way. And there was no way to really express this or understand this from the framework that I'd had of my own subjectivity before. But it was very, very present to me. And I think partly in response to that, I began writing to my unborn child. I wrote journals and, continued that project, after she was born. But I think part of that writing was to try to get a sense of this separate being that was in the process of being formed inside of me, part of me, but not me. And I also was aware of the fact that, as my body was changing and developing, A number of the things that were used to be mine and were such touchstones for me about my identity now no longer were really available to me. I used to run. I mean, I run again now, but I was a regular runner. I ran early on in the pregnancy. I remember running a series of 5K races and seeing my time slow down, as I got further and further into my pregnancy. But really, after the first trimester, I remember one moment running in the woods and then tripping and falling. And what a difference it was to trip and fall, when I was pregnant. And at that point, I decided I wasn't going to go running anymore. Just it was too concerning to me. But this sense of like I had to let go of these things that are habits that are so that have been so important to me. And what am I going to do with that? And who am I without these things? So, as Susie, as you might imagine, I found your text to be very, very important after the fact, just looking back and understanding that. And as I think you'll probably see today, very important for how I'm thinking about peripartum psychosis as well. So I'll kind of shift into talking a little bit about that. I will be reading for a good portion of this talk, but I also have a couple of things I will share with you guys toward the end as well, some video. Um, so Husserl described pregnancy as a limit case of lived experience. Pregnant with child, I can experience the movements and shifts in my body as mine, as my experiences that only I have access to in this way. And yet, feeling the kick of the fetus, seeing its movements on an ultrasound, hearing the beating of its heart, I become aware that this is something that surpasses my consciousness. The pregnant individual and her body are necessary for the barest existence of this other that's being created within her, an other of which she has her own experience. But this new being exceeds her intending of it. It is forming itself and its own world at the same time that this existence can rest only on the existence of the mother. It would not exist without me, and yet it is already not entirely just me. This is perhaps the most radical challenge to lived experience, but pregnancy, childbirth, and early and all motherhood point to other limits of consciousness. The mother's body changes dramatically, following a biological program that she cannot stop or do much to alter. Women describe the process of labor as one of being hit by waves of contraction that similarly cannot be stopped but must just be survived. And then there is the inundation of institutional structures and societal expectations related to pregnancy and motherhood, which can be partially ignored perhaps, but never completely erased. These inescapable features of subjectivity occurring in the transition to motherhood, that is, in the period called the peripartum, point to a fundamental ambiguity in subjectivity, one that exposes and pushes against the illusion of a separate autonomous self. It is perhaps unsurprising that, in facing this potentially radical transformation of experience, pregnant women and new mothers find themselves in a place of profound psychological vulnerability. One estimate suggests that 85% of mothers experience some form of distress during the peripartum, ranging from low-level dysphoria, sometimes called baby blues, to increasing levels of anxiety, obsessive-compulsive symptoms, mood alterations, and, at times, psychosis. Peripartum psychosis is the least common, but viewed as the most severe form of maternal distress, affecting about 1 or 2 per 1,000 women. Reflected in the ICD, the International Classification of Disease, but not a distinct diagnosis in the current Diagnostic and Statistical Manual of Mental Disorders, or the DSM. Peripartum psychosis refers to a cluster of symptoms occurring in the weeks or months following childbirth, although sometimes leading up to childbirth as well. These symptoms include hallucinations, delusions, significant changes in mood and in sleep, and the potential for confusion, disorientation, and other changes in awareness, often with rapid onset. Research on the etiology of the illness is inconclusive, but tends to focus on hormonal and neurochemical shifts and abnormalities, including the abrupt decrease in the hormones estrogen and progesterone following childbirth, as well as the role of prolactin. There's also evidence indicating a link between peripartum psychosis and bipolar disorder, such that one recent review has suggested including it as a distinct diagnosis among the category of bipolar disorders in the DSM. But life stressors also clearly play an important role as well. difficult or traumatic pregnancy and birth experiences, problematic family support, and difficulties related to breastfeeding, as well as lower socioeconomic status and other forms of stress, have all been linked to the development of this condition. In discussing peripartum psychosis today, I want to propose that the full peripartum period, from pregnancy through childbirth and the postpartum phase, needs to be considered in its entirety in order to adequately address the experiences involved in psychosis affecting pregnant women and new mothers. I further want to argue that these processes are significantly impacted by the personal, social, and cultural atmospheres in which pregnancy and childbirth occur. To arrive at this point, I'll start with a look at one vivid depiction of the experience in Catherine Cho's memoir, Inferno. I will then turn to feminist phenomenology's insights into the nature of pregnancy and childbirth, or nature of pregnancy and motherhood. And I suggest that the experiential transformations heralded by pregnancy and childbirth force us to consider peripartum psychosis as an expression of subjectivity that is not different in kind, but is continuous with maternal subjectivity, and which reveals something crucial about the nature of subjectivity itself. Ultimately, I argue that peripartum psychosis should not be understood as a breakdown within an isolated subject, but instead as a crisis of subjectivity that is open, embodied, and situated in the world. So Catherine Cho's memoir, Inferno, offers a vivid case study in peripartum psychosis. So this is a book that was published several years ago, but is still relatively recent. And it traces the author's struggles to navigate profound transformations in subjectivity as they come into conflict with the constraints of social and cultural expectation. Although her acute symptoms of psychosis emerged several months after childbirth, her experiential changes begin during her pregnancy, encompassing shifts in embodiment, temporality, intersubjectivity, and identity. During the prenatal period, Catherine grapples with the semi-independent existence of her unborn son. She writes, "I held my hands close to my stomach and tried to feel the tiny beats of his legs, the pulse of his body, the reminder that he was alive, a living thing, while at the same time feeling a strange distance from her own body." She writes that pregnancy felt like a separation from the body. My body was doing something on its own, a pre-programmed path it already knew, and I no longer had any control over. It was also an erasure of self. My body was no longer my own. When her son is delivered, she remembers thinking, "Are you sure? He didn't look like either of us." And later, "I didn't feel a rush of love or an overwhelming weight of responsibility, emotions that I'd been expecting. Instead, I felt curious, like I'd just been introduced to a stranger." She is surprised by the sheer physicality of caring for her son, how her body still is not really hers, even though her son is no longer inside her. Catherine is grateful for the brief time she has to herself, when she can remember that she had a self, that I was something more than a mother, though she struggles with this notion of identity, of fully embracing her new role as a mother, and of her feeling that that role had changed everything for her. Writing, "My identity, my existence had shifted without me realizing it. The axis of my world had changed. Everything was now in relation to this other life." As a Korean American, Catherine is acutely aware of cultural prohibitions against travel in the first 100 days after birth, but decides with her husband to voyage from the UK to the United States to introduce her son to her extended family. She first becomes aware of difficulties after she realizes that her brother-in-law's house has numerous nest cams, which she initially laughs off, but starts to become more preoccupied with. Visiting her parents-in-law in New Jersey, she faces what feels like a barrage of criticism related to her decisions as a parent and her son's health. Feeling trapped and stifled, Catherine starts to experience more and more stress. Later, she discovers that her parents-in-law have Nest Cams also, which are accessible to her husband's brothers as well. When she expresses her concerns to her husband, he dismisses her. Soon, Catherine starts to have the sense that her mother-in-law is sending secret signals to her via gestures and eye movements. Catherine feels it is necessary to leave their house, at least temporarily, so she goes with her husband and son to a hotel in town. But while she's there, she becomes even more convinced that she's being watched and filmed. It is at this point that she looks at her son and sees his eyes as devil's eyes, and others' faces start looking distorted to her. Catherine hears the voice of God telling her that her son must be sacrificed. She has repeated visions of her son, dead, in her husband's arms, and she starts to feel that time is looping and splitting off into different possible futures and bringing the past into the present, with intrusive memories of her own traumatic past and visions of the imagined past of her parents and ancestors. Ultimately, her husband takes her to an emergency room where she's put in restraints, given antipsychotics, and eventually committed to an involuntary psychiatric ward for over a week. During this time, she's separated from her son and has brief phone contact and infrequent visits with her husband and parents. When she's discharged and reunited with her son, who by then is bottle feeding, she has difficulty recognizing him or experiencing an emotional response. She writes, "We were separate beings, truly separated. It was like he had been cut from me again." Upon return to her home in London, she falls into a deep depression that lasts for several months, during which she continues to struggle to feel a sense of connection or capacity to care for her son. Gradually, though, this returns until one day, she writes, "An ordinary day. As I was holding him, I remembered him. His smile, the feel of his breath on my arm, the warmth of sun against our cheeks, the weight of his body against my own. And I was a mother again." So with this text, which, as you can feel, is an incredibly moving text, and sweeps you away as you read it. Um, Part of the experience of reading it is just being present to her experience. And I think in and through that presence to her experience comes a place of starting to make sense of that and starting to think about it. And one way to do this, one starting point, although this is not where I'm going to end, but one starting point comes through the lens of phenomenological psychopathology. Now, this is an approach to understanding mental illness that draws on philosophical phenomenology, so the branch that Susie is in, to inform the understanding of mental disorders. And it views the symptoms expressed by somebody with a psychiatric diagnosis as manifestations of their subjective experience. Okay, so any symptoms and are expressions of how self-experience occurs, how it is that they experience others, and how they experience the lived world. So I'm not going to go into depth into this approach, but just to say a little bit about what this kind of stance and what this discipline might have to say about Catherine's experience. And here I share some work from some students in my lab, some undergraduate students who also worked with my graduate student, Tate Hudson, to start to think about, the range of descriptions that Catherine has throughout her text. And so from this approach, Catherine's body can be understood as coming to feel like an object to her, indeed an alien object, one that's separated from her subject body, one that performs processes that are not only not in her control, but that feels strange and radical, in radical contrast to her habitual sense of her embodiment. This estrangement becomes exacerbated as she develops a heightened awareness of her body as an object for others through the nest cams, who appear to be scrutinizing and criticizing her actions as a mother. She begins to experience then others as persecutory, and arguably they are, but this can lead to her to kind of perceive this demonic antagonism, perhaps in the perception of her son's eyes as devil's eyes. Her own identity becomes radically called into question as she feels herself losing touch with her prior identity in the face of the demands of motherhood, to the point where her sense of mission and sacrifice appears to radically transform her view of herself as one who is called to obey God's demands for a sacrifice. She becomes increasingly disoriented in time, particularly in her psychosis, in which memories of childhood and prior abusive relationships resurface and intrude on the present, and visions of unlimited possibilities for future timelines disrupt her capacity for goal-oriented activity. And her recovery ultimately appears to involve a process of integrating these challenges to identity, integrating her awareness of her past and the relevance of that for her current experience, and also starting to think about how to respond to the unwelcome intrusions by others, a changed relationship to her own body, and her developing capacity to respond affectively to her infant son. Um, Now, I want to say I think that this kind of structural framework is really important for starting to understand Catherine's experience and her transition into psychosis. But where we have to be careful, and this is something that can show up sometimes in this field of phenomenological psychopathology, is to kind of move to seeing this as evidence, as solely evidence of her own pathology, seeing something kind of individual and intrinsic to her that is giving rise to these experiences. And in fact, I want to say that in looking to literature on the phenomenology of pregnancy and motherhood, these experiences actually reveal fundamental features of subjectivity itself, notably its porosity, its passivity, and the role of institution. And these are facts and features that are brought into high relief in maternal experience. So I'm going to turn to the field of feminist phenomenology to help us explore the nature of these features as they are exposed in peripartum psychosis. So here I'm going to start with the concept of porosity. In the field of feminist phenomenology, pregnancy is discussed as a condition in which the illusions of separateness and unity are laid bare, where the woman's body is both herself and not herself. Its movements are hers, and yet they also belong to something that exceeds her. Here, the placenta offers itself as something Lachance and Adams and Lundquist call a vital mediating space. This is an organ that preserves differentiation within the relationship. There's neither fusion nor conflict, but a negotiation. Similarly, Florencia Verhaya sees pregnant embodiment as suggestive of philosopher Merleau-Ponty's vision of the contact surface. This is a relation between body and world that is permeable, pliable, and allows for exchange between, quote, two separate but connected entities. Catherine's experience testifies to the shock that this newly recognized porosity can bring, as she describes how her identity, my existence, had shifted without me realizing it, and takes actions to remind herself that I was something more than a mother. Confronting the newborn as a separate entity can then be shocking after this sense of merging and stretching of one's own boundaries of the self. Simone de Beauvoir suggests that the new mother faces surprise, sadness, and estrangement at first meeting her child face to face. She writes that the being would not exist without her, and yet he escapes her. The woman would like to feel him hers as surely as her own hand, but everything he feels is closed up inside him. He's opaque, impenetrable, apart. She is stupefied by the indifference with which she receives him. Of course, this is not the whole story, but it is one aspect of the story. Catherine's sensation of meeting a stranger, her attempts to grapple with the identity of her child and related confusion, her lingering feeling of disconnection all seem to refer, at least partially, to this new phase of the continued process of renegotiating the boundaries of self and the relation to the new being created within one's body. In addition, this porosity extends beyond the mother-child unit, indicating the ways that subjectivity always involves an open interchange with the world. This notion of the porous or open subject is prioritized in phenomenological discussions of atmospheres, notably in the new phenomenological tradition developed by Hermann Schmitz. And here I'm truly indebted to Cynthia Dorstein for allowing me to become familiar with this area for her own expertise in this body of literature. But Schmitz and others in this new phenomenological tradition recognize the ways that experience cannot be understood to be simply within a person, but rather that individual experience is an expression of affective atmospheres that invade them. This has been described as a debordering of experience. The individual may be the locus of the experience, but that experience is not only within her. That is, not only are we responsive to the affective atmospheres around us, but those atmospheres, which may be atmospheres of fear and mistrust, or of safety and comfort, can be understood to be fundamental to subjective experience. Here we're called to recognize how Catherine's heightened porosity in her encounter in pregnancy and childbirth may also render her increasingly open to the atmospheres around her. Her porosity is not pathological, nor even distinctive of pregnancy, but may render her more vulnerable during this time to the affective responses of her social and cultural world. I will address this issue again when I take up the notion of institutions in a moment. Pregnancy, labor, and breastfeeding all force a woman to recognize with her own passivity. The pregnant woman also becomes aware of the anonymous physicality of her experience, the ways that her subjectivity, and perhaps most obviously her body, heeds its own call outside the dictates or desires of the conscious ego. This physicality extends to hormonal changes and changes in cortical structures, as women find that their basic affective and cognitive habits and tendencies are changed outside of their awareness or control. Dylan Trigg notes how this physical anonymity is especially present during childbirth itself, finding that this transformational moment shows how, quote, the body can appear for us irreducibly as one's own while also never being entirely possessible by the subject. Nausea and insatiable hunger, fatigue and surges of energy, body aches, heartburn, sleeplessness, heightened sensorial and emotional sensitivity, the phases and movements of labor and childbirth, all of these come upon a woman, requiring her constant adaptation and adjustment. So the pregnant woman becomes passively swept into a flow that exists beyond and before her, but one that she can, in some ways, take an active stance toward. This is something called pactivity, so passivity activity, by the philosopher Jana Bornmark. This is apparent also in breastfeeding, where, as Verheyen notes, quote, rather than quietly settling into a purely natural process, I am again creatively engaged in and struggling with an action over which I do not have full control. Catherine similarly describes a sense of strangeness she feels from this new relationship to her body. She writes, my body was doing something on its own. It was no longer my own. This passivity or receptivity also appears to extend beyond the childbirth process to perhaps Catherine's unusual perceptual experiences, her intrusive or confusing thoughts, her unbidden memories, and perhaps some of her automatic associations to personal and family past. Crucially, these and other experiences take place within a particular sociocultural context, one in which established institutions, both concrete and ideological, are unavoidable. Feminist phenomenology exposes the discrepancy between the lived experience of this expanded subjectivity, its intimacy and familiarity, and the objectification of medical institutions, which often emphasize control and measurement. Iris Marion Young and Louise Levesque-Lotman both note that the pregnant woman is primarily addressed within the medical setting, with the consequence that her state is assumed to be abnormal, even sick or diseased, and needing management and treatment. Here, the doctor is the one with the specialized knowledge, and the woman is the patient, the passive recipient of this knowledge. Her welfare, according to this model, depends on the degree to which she conforms with the advice and strictures of the physician. Similarly, others have pointed to the effects of popular discourse in the conceptions of motherhood. This include Hayes's identification of the cultural shift of the 1990s, at least in the United States, towards something she calls intensive mothering, which involves wide-ranging expectations that mothers be highly devoted to their children above all else, a devotion which includes frequent turning to experts for guidance. Consistent with these arguments, dominant themes in maternal mental health handbooks include an emphasis on the mother's well-being primarily in service of the family, the medicalization and individualization of distress, and the need for expert clinicians to treat mothers with perinatal distress. Such institutions are certainly present in Catherine's life as she becomes hyper-aware, perhaps via heightened porosity, of the expectations and worried watchfulness of family and friends through their constant questioning and critiques, made concrete when she's literally being watched by security cameras in her relative's home before she's taken to a hospital where nearly every movement is scrutinized and controlled. Porosity, passivity, and institution. These features stand out in the experience of pregnancy while pointing to qualities of subjectivity that are present, if ignored or overridden, in all subjectivity. These qualities highlight the ways in which my experience is no longer just mine, but is something other than itself. Pregnant individuals are faced with a newly expanded awareness of the boundaries of their subjectivity, finding these to be more fluid and open than they had been aware of in the past. They're also aware of the uncontrollable acts of the body, to which they are more, though not entirely, passive observers. And they're faced with a range of internalized and externally expressed institutional expectations related to motherhood, which may be drastically at odds with their experiences. Such openness, fluidity, and vulnerability may trigger a radical transformation of identity and self-awareness, one that starts with pregnancy but continues long past childbirth. But many institutions associated with motherhood leave very little room for understandable confusion, tension, distress, and discomfort that result from such a transformative experience. It's easy to see how experiences, thoughts, feelings that do not conform to this discourse, and that instead attempt to express these impossible splits, can get taken up as a problem, one that may be alternately treated as a medical illness, dismissed as a momentary weakness, or hidden away as a shameful secret. The woman may find herself caught between two worlds. The one of her own experiences that are undeniable but that cannot find any home or harbor, and the one reflected back to her as the correct or healthy way to experience pregnancy and motherhood. We might say then that the significant distress and alterations of experience here are not the provenance of the woman as some separate individual, but surface through her as an expression of her participation in the world, a world that too frequently prioritizes control of the physical, knowledge of the self, and the idealization of motherhood, while fearing ambiguity, uncertainty, and risk. Indeed, in encountering her own disorienting and vulnerable experience as a new mother, Catherine simultaneously runs up against the inescapable expectations and pressures of others. With no conceptual or relational standpoint from which to articulate the distress that arises from this transformation and conflict, she's eventually pulled into an isolated hell, one that gets labeled as psychiatric symptoms that result in her hospitalization. So what I want to do here is just briefly share a clip from the recent film Die, My Love. This is a film that came out this year. It's got Jennifer Lawrence in it. And uh, this is an interesting and I think in some ways a controversial film about madness and motherhood. I think one which often gets read as a kind of straightforward depiction of as one of my students put it, the way a mother gradually becomes sort of more and more crazy and eventually sets fire to the woods and walks into it naked. Um, but I think on another level, and the way that I take it, it is a depiction of the impossibility of motherhood and the impossibility of kind of finding one's way with it in a world that really doesn't have any footholds for just the intensity and the immensity of that experience. So I'm going to show this clip. Let me see if I can do this here. Um, so, okay. This clip, hopefully, can you see the kind of the YouTube screen here? Okay. So this clip comes from a moment Jennifer Lawrence is at a party, kind of the first party she's been to since becoming a mother, and is talking to somebody else at this party. So we'll watch this here, and I'll talk a little bit about it afterwards.
So do you think you'll have another one?
Yeah, pregnant now. Picking up twins.
What happened to your hands?
Oh, you should see the wall.
Yeah, I have two kids and two is a lot, if I'm being honest.
Seems like it.
Don't grow babies though. Babies are hard. I don't think anybody talks about that enough.
It's all anyone talks about.
It changes you. I think I nearly lost my mind for the first 6 months.
When do you think you'll be getting it back?
Yeah. You know, postnatal depression is so much more common than people think. What do you do for work, Crave?
I don't. I'm stuck between wanting to do something and not wanting to do anything at all.
Oh, hang on. Cheryl mentioned that you're a writer. That's cute. That must be nice having something you can kind of squeeze around a bit.
Yeah, I don't do that anymore.
Why not? Stuck for inspiration? I'm sure it'll come back.
Okay. So I'll stop there. Just see if I can bring back my slides. Okay. So this clip I think is really interesting, and I think it expresses a lot. I take from it, both well-meaning attempt to empathize and connect with somebody who's struggling, and also the failures of that attempt, and the ways that we can sometimes try to place the immensity of that experience in a really neat package that allows us to talk about it and to talk easily about it, and then to be able to move on, to talk about it as cocktail chatter. And the resistance of Jennifer Lawrence's character to that kind of encapsulation and the kind of violence that's what that sort of encapsulation can do. So it's I think this is a very normal conversation in some ways, and one certainly that I resonate with, and I don't find fault with that that individual, the mother that's talking with Jennifer Lawrence's character, and at the same time, it makes me think, God, there's got to be other ways to do this, and what are those other ways, and are we making space for that together? Okay, so I'll just leave that there. Maybe we'll talk about that a little bit more. But I think that just the last things I want to say is that when we ignore perinatal subjectivity, this almost ensures pathologization of otherwise normative experiential transformations. This, as we've seen in Catherine's narrative, can drive those experiences underground, creating an atmosphere of fear and shame. Similarly, a focus on individual pathology ignores the nearly inescapable situations in which psychosis occurs, where women's experiences and concerns find no harbor but are viewed as increasing evidence of their instability and unfitness for motherhood. If instead we view peripartum psychosis as partially expressing a socio-cultural incapacity to face and contextualize the unique subjectivity of early motherhood, it requires a very different stance toward prevention and treatment. Medical professionals will be counseled to take time with women to hear their concerns and establish relationships of trust and support that permit true shared decision-making around pregnancy, the birthing process, and beyond. Similarly, treatment would recognize the delicate state of the new mother's subjectivity, one that is naturally finding new contours that must take into consideration the newborn as well. Keeping the mother with the newborn and supporting her as she works to understand and integrate the more distressing or intrusive aspects of her experience seems crucial, particularly to the ongoing development of her identity and to the porous interface between subject and world, which starts with childbirth. All of this requires a significant cultural shift in perinatal medicine, psychiatry, and popular discourse, at least in the United States. Here, prevention and care then becomes a social and community concern in which both formal and informal discussions of pregnancy and motherhood include all the messiness, uncertainty, and challenges that occur in these situations. Okay. And I just want to thank my family, Cynthia, my lab here at Duquesne, my students, Maya, Mo, Benjamin, Amelia, and Tate, who assisted greatly with work on this project, the Duquesne Psychology Department, and my university. And I'll stop there. Thank you.
Thank you so much for the beautiful presentation. If you can close the screen, we can see you. You
Yes.
can see your face.
Yeah, let's see if I can do that. Hang on. Sorry, one moment here. There we go. Okay.
Thank you. Thanks. It's a very important topic. Do you have, Tate, a question to broach a conversation together? Okay. If you want to type anything, I can read it. Yeah, I mean, while you were reading the story, I mean, while you were talking, I had a curiosity. Do you think that the possibility to build a corporeal scheme during pregnancy might help creating the contact? I don't know. Of course, I felt very much the story of the woman you shared, and yeah, it was really clear that she felt detached from this baby, and the best was feeling curiosity toward this baby.
Mhm.
And it was beautiful how the curiosity came back in an embodied way on an ordinary day.
Mhm.
Um, I wonder if, yeah, and this is something, yeah, I try to say also in my book. This medicalization process that starts around the end of the first trimester and brings the body of the woman to be objectified. Um, I don't know, slows down the process of, but it's as if the woman loses the responsibility of her body because doctors can handle it better. Doctors know how to do this. And slowly we pass the torch of the ownership of the agency of our body to someone else. And so it's hard to create those intersubjective corporeal scheme that can be triggered by, you know, the first kicks and the heartbeat and so on. I don't know. What's your take on this?
Yeah. I have kind of like two sort of parallel thoughts with that. One is, I think that, any work and attention in that regard, right? That helps the mother to kind of become in touch with and responsive to kind of her own bodies and the changes that are happening and grapple with the loss around that and that like all the feelings that can come up with that too and then like learn, okay, how do I navigate this and what is being called for, and I remember that is really touching me from your book is like, how do I start to like actually listen to this in a way that I may have never needed to listen before, right? How do I move beyond the sense of like whatever kind of control I had or like this works for me for now to like, okay, like what are actually the messages there? So I think that's huge and I think that can start in pregnancy and sometimes I think it's really very much called for by pregnancy. And then at the same time, would that have solved things or made things better? I don't know. I don't know. And I think about so just as sort of an example along those lines, I did uh, prenatal yoga classes, which were great and great in different ways. I mean, part of it was just kind of the physical element and kind of, being able to kind of work with the body. Part of it was a social element as well, and having space to talk with other pregnant women and hear a range of experiences and, get the sense of like there's all different ways to be pregnant, right? And space for that. And then, some of that was also kind of preparing for labor and childbirth. But then labor happens and then there you are, and you are doing um whatever, in that moment. And I remember afterwards, and my child was born during COVID, and so I mean, that's a whole nother thing. But we got together, that group of women who was in that class, we all got together online after our children were born, and we're talking about it. And I remember talking, and my experience about like my disappointment, some of my disappointments about some of the things that happened through the labor process. And the yoga instructor, who was also a doula, said, "Yeah, like we have all these ideas about what's going to happen, and then it happens the way it's going to happen." And I think that's the piece here too, is like, you can do all of this stuff, and all the things that are sort of called for to pay attention, and it still is not. It's not perfect, or it's not going to work, or you still end up being disconnected from your body, or it's still distressing, or it's still all of this stuff, and so to have that space for being open to whatever comes and then working from that. And that's one of the reasons I like that quote from Simone de Beauvoir, which is to say, a lot of women feel that sense of alienation from their baby, from their body. And not everybody does, but a lot of people do. And it's understandable, like, God, like, of course, in some ways. And so if we can have space for that, and that's like disconcerting and it's not what we expect and maybe there's something ways for us to respond to it but also we have to acknowledge that that's what's there. I think it's got to be both, right? It's that activity. It's like, okay, you can take active steps to respond to what's happening, and in some ways you're along for the ride, lots of ways.
Yeah, we have a comment from Tate. Ah, no. All right.
Thank you, Tate. Thanks for joining.
Yeah, it's that's something I start thinking as I hold these webinars. That as women, we enter in the process with a number of expectations, especially the first pregnancy, because after that we know, I guess. We enter in this process with an expectation. They asked us to fill out this birth plan, which is a kind of a unicorn.
Yeah.
Now we
Yeah.
know.
Yeah.
It's something to keep us at bay, more or less, I think. And one way or another, there's always space for disappointment. Because I don't know, because uh, one thing I'm noticing we don't feel heard. And that happens quite often in the passage from pregnancy to early motherhood. There's loneliness. But that then in the clip you show, there's an attempt to create a bridge, but still the loneliness is so ontological, existential. It takes every space that, it's hard to overcome. What are we doing? So I don't know. What can we do?
Yeah. Yeah. I think that, in when I think about this kind of, kind of massive, uh, kind of thing that women encounter in this process, there's both the, psychosis, or, this can also show up in, perinatal, what are, described as perinatal mood and anxiety disorders, where there's that distress and feeling of disruption and not being able to wrap your head around it, or not, not knowing what to do with it and feeling kind of lost with it. And there's that acute moment, and then navigating that. And I think really also a lot of sort of responsibility for caregivers and, people in relation with the mother to be present with them in that. And then and then there's everything else that happens after that, right? Then there's like the kind of the coming to terms with, like this, this happened, and it's not what I wanted, and I did my best with it in the situation. And yet, I like, and now I've got to live with it. I've got to live with the fact that, I had this disruption, and, I was, if I was hospitalized, during that period, that I wasn't, maybe I wasn't with my baby, or maybe, I wasn't able to breastfeed as a result of that, and all these things that I thought were going to be present. And so, I do think there's that, that sort of responsibility in the moment to really have structures and listening and responsiveness, and really, both dialoguing, and also saying, okay, how do I really help this person sort of right now, and help them in all the ways I can. And I think also what I want to say is that, those are hard decisions, and it means that, people don't, they don't know what to do. They do the best that they can, and sometimes those decisions, they do have consequences, but, um, like, how do you know? How do you know what's right and what's not? So I think that having these conversations and raising this awareness helps people to make those decisions. And at the end of the day, they're always going to be trying the best they can. And sometimes, sometimes mistakes happen, or sad things happen, or difficult things happen. And then, and then you have to work with that, and then you have to live with that, and then you have to address that. And to also have space for that, okay, that was a hard time. I didn't want to be hospitalized. I didn't want to have medication. I didn't want to be taken away from my baby. And yet this happened. And now we're going to move forward. We're going to move forward from here, but also with acknowledgement of the loss and the sadness and the disappointment too. And you can have both of those. You can have both of those.
Yeah, Yeah, what you're saying reminds me of a presentation from Alison Stone.
Mm,
I don't remember the title. I think it was about being born. And she tells the story of how she got ready to her delivery. You know, she had all her plans with her partner. I don't remember if it was husband at the time, but anyway, she knew that, okay, she would have kept working, and the partner was happy to take care of the child. So everything set. And then the child arrives, and he doesn't want to separate from the mother.
mhm,
And she feels overwhelmed and starts feeling depressed. And she starts going down, and she says, and as far as I understood from her talk, she strongly desired her child. And then she starts meeting with the therapist, who basically encourages her to name things as they are.
mhm,
Because, yeah, as you were saying in your presentation, the institutions can make lots of expectations on us, on what we should feel. And so through psychotherapy, she starts writing down what actually brings her joy.
mm,
Being able to, the highlights of her day, being able to run for 10 minutes by herself. And she builds slowly on that um, what her present life is, and how it can improve. Um, which I don't know, it seems a little bit the invitation you are presenting now. There might be many things that go wrong, many decisions we have to take that are tough and are going in the direction that is not ideal for us. But then we have to deal with what is present and find, it seems to be the most important thing, to be able to find ourselves in that moment, and to be there and to embrace what good is in that moment. And sometimes it's dark. I get that.
yeah,
Yeah.
yeah, yeah. Well, and I think this question of like, who is this myself now, right? Like,
Yeah.
um, it's and I like one of the things I also really love about that film, Die My Love, is how incredibly alive and vibrant Jennifer Lawrence's character is. And then like she's like, and then she doesn't know what to do with that, once her child is born. And like, how do you bring that in? Because that's still there, but it like there's a way in which it like doesn't fit or it doesn't flow. And like what you're kind of like, okay, I've got these new sort of constraints and possibilities and some of these old habits, these old things I know about myself,
Yeah.
like what do I do with that? And so um I find myself reflecting, now like almost 6 years out from the birth of my child, and the sense of like, oh, I do, I kind of do start to feel like myself again. But I just, it's such a funny thing because it's like, well, what does that mean? I don't feel like the me before,
No, no.
but it's much more like, oh, like I actually feel like I know, like I identify with myself, right? Like
Uh-huh.
I feel that sense of like familiarity,
Yeah,
but
yeah.
it's not a return. It's a return
No.
to that feeling of familiarity, but it's not a return to the familiarity of before. It's the
Mm-mm-mm.
new one.
Mm-mm.
And so yeah, this kind of this work, this sort of ongoing work to say, okay, the stuff that's coming up, and in Catherine Cho's text, I mean, what's so one of the things that's so vibrant for her, all of these memories that come just resurging about past
Mm.
relationships and her family upbringing, and then thinking about her cultural heritage and what she knows about her family's history. And like this doesn't come up for no reason, it's disorienting to her, but it's coming up because it's begging to be integrated in a new way,
Yeah.
right? She's got to kind of now, what do I do with this now that I'm a mother, right? Like, how does that now fit in this flow, and what am I going to do with it? And I think in some ways it's active work and it can be done like with therapy. And then I also think in some ways it's like, you know, just through the movements and the activities and the new habits and the making your way, the messy way through motherhood that also takes place. Um,
Completely.
yeah.
That's really beautiful. Thank you, Elizabeth. Yeah. Because in the meantime, you have to be mother. I mean, you are doing this work. There's a work of integration that begs to be done
Yeah. Yeah.
actively. That's a
Yeah. Yeah.
fantastic
Yeah.
expression from Jonna Bornemark. Uh, but at the same time, I mean, the job you are called to do is demanding, is daily. It leaves you sleep deprived, it depleted with your body. Um,
Yeah. Yeah. I know. I know. Sometimes it feels like the superhero origin story,
yeah,
like
yeah,
what are the trials that I need to go through, or that, and then like comes out of this like, totally like powerful and also,
yeah.
but also wounded, person that's now going to, has to rise to all these tasks. Or
Has
like
to rise.
you and I were talking before the talk
Yeah.
started too, like at each stage is like that. Each phase of motherhood, it's like, okay, what what new hell am I going to be called to address? And who am I going to become through that? What is that
Yeah.
going to ask of me in terms of my developing identity?
Yeah. And it's a beautiful, so I mean, when you start rolling with that, it's coming back to be a child, right? When you celebrate the birthday of your child, you realize, okay, I'm 4 years old now. I'm 3 years old. you, it's that kind of amazement that is truly warm. But in early motherhood, I don't know, it's kind of scary. I can see, I mean, I remember in my case, I was dreaming of dying. I mean, of me going to my own funeral
Mm.
twice, 3 times a week. I
Oh yeah, yeah, yeah,
mean, I having done my research and I knew that that was in the air.
yeah,
But your
yeah,
dreams are your dreams. I mean, it's not something constructed, intellectual. It's there, and you are attending your funeral, and
yeah, yeah.
uh, you're saying,
Well, it's similarly, I would have kind of intrusive thoughts about my house burning down. It's like,
ah,
you know,
yeah,
but it is, I mean, whatever. I
huh?
speak a little bit more as like a clinical psychologist than kind of as my phenomenological researcher here. But yeah, I mean, it's an end of something. It is a burning
Mhm,
down of what was.
mhm.
And then what gets reconstructed on the ashes, what gets born out of the death.
Yeah, yeah. That's and being able to accept that.
Hmm.
And also to know that when you start, but it's almost impossible to understand it for as much. I mean, I think phenomenology is producing fantastic work, qualitative work to give the sense of how this experience feels like. But I think we need to do much more because it's so hard to convey completely to a person who wants to get pregnant, who is pregnant, really the normality of the challenge that is ahead. And I don't know if that would help
Yeah.
anyway,
Yeah, yeah,
if it
yeah,
changes anything.
yeah. Well, I think one thing it calls for all of us, and I want to say here, this is something that I have learned and continue to learn from my work with folks like Tate and like Cynthia, but is this willingness to be affectively engaged with the experience, whether that's our own experience or the experience we're encountering with others, but that this isn't, some separate intellectual research project.
No.
It's not some separate other that we can give advice to or just tell, just do these different things. It actually calls for us to be present, present to that experience. And I actually think that's how good phenomenology is going to be done with it. And I also think that that's how, any kind of connection or any kind of bridge to somebody who feels alone is going to happen.
Mm-mm. Because in that clip you presented, you can tell that that woman had an agenda.
Oh, yeah. Yeah. Yeah.
Uh-uh.
Yeah. Yeah.
She was, as you said, well intended, but she was worried for her and she wanted to give her advice, which she did in a passive, indirect way. So she wasn't present.
Yeah.
She
Yeah.
was worried that she was well meant, but she wasn't present.
Yeah. Yeah. Yeah.
Mm-mm. Elizabeth, what can I say? we're doing our best.
Oof. It's so important. I think it's so important. And I'm so grateful to you and your group, Susie, for what you guys are doing.
Yeah, same here for you, because I mean, I imagine that doing this research takes a toll. I mean, just only listening to your presentation, I was in tears. So I can't imagine how it feels like to, come in contact with many stories, being present for them, doing the intellectual work of translating everything into something that is scientific enough, is academic enough. So yeah, thank you for doing all this job. It's
Thank you.
yeah, it's commendable.
Mm.
And unfortunately, nobody is asking questions. I see someone on on the YouTube. So if at some point any question comes up, they know they can ask on the comments, on the chat box for the comments. And yeah, meanwhile, I thank you for your time, for being here and delivering this fantastic presentation today.
Oh, thank you so much, Susie. This was such a treat. Really wonderful.
Thank you. Looking forward to seeing you in person in
Yes,
some
likewise.
months.
Yes, absolutely. Okay.
All right. Ciao, Elizabeth.
Bye.
Have a good day.
Thank
Bye.
you.